Welcome to the Panorama Patient Education Network. I'm Dr. Matt Stern, your host for today's roundtable discussion on neuropsychiatric symptoms associated with Parkinson's disease. I'm joined today by my distinguished colleagues, Dr. Daniel Weintraub, Professor of Psychiatry and Neurology at the University of Pennsylvania and a world-renowned expert on the neuropsychiatric features of Parkinson's disease, and Dr. Rachel Gross. Dr. Gross is a neurologist formerly on the faculty of the University of Pennsylvania's Parkinson's Disease and Movement Disorders Center. She is now a practicing psychotherapist who specializes in the psychiatric treatment of patients with Parkinson's disease. I now want to turn to another problem that we see that's been problematic for a number of patients, and one that is more often part of the drug-induced spectrum of neuropsychiatric issues, and that's the problem of hallucinations, delusions, fall under the umbrella of psychosis. And again, there's been a lot of interest in this lately. There are some medications that are now available to treat it. But Dan, can you give us a little capsule of what patients may experience? Because there are different types of psychosis in Parkinson's.
That's true. And as you already highlighted, there seems to be a strong contribution from the Parkinson's disease treatments or medications. It's one of those disorders, psychosis, that I think is a mix of the etiology or cause being from the treatments that we provide to the patients, but also the advancing pathology that patients, the advancement of the disease in the brain over time. So it's some kind of a mix that's not always easy to disentangle. As you noted, though, we have a recognition and an awareness now that maybe up to 60% of patients may experience psychosis at some point.
So many of them late in the course of Parkinson's.
Yeah, I don't want to be alarming there, but if you follow patients long enough, this can become an issue. Now, the other thing that's
these could be benign, too. These could be a little, have you seen patients that complain of seeing a little shadow or something like that?
Yeah, or even just feeling like somebody passed in the hallway, or I've had people have some sensations that are actually comforting to them, like a presence hallucination, where they just feel like there's a guardian angel there.
So they're not
nothing
always
frightening.
Yeah, so they're not always frightening. In fact, they're often not frightening, right?
I would say that perhaps up to half of patients that experience these changes, it's not so clinically significant that it warrants treatment. So
right.
it's a real mix. I'd say the benign hallucinations, we call them, where you may experience a visual hallucination, but it's not frequent enough or troubling enough to warrant intervention.
When it does get bad enough to warrant intervention, what happens? What are some of the symptoms that patients or caregivers or families will talk about?
Well, I think when they're warranting intervention, in my mind, it's because they're causing distress to the patient or to the family member. I mean, sometimes it's hallucinations, sometimes it's delusions, right? Which would be like
what's the difference?
Like, well, hallucination would be something that you're seeing or hearing or feeling, whereas a delusion is a belief, a false belief, but it could be held onto very tightly and thought by the patient to be true. And that can cause a lot of trouble.
An example of that would be something like marital infidelity.
Right.
You think that your spouse is having an affair or something like that.
Right, or fear that there's somebody breaking into the home or something like this. And you could see how distressing ideas like that would be, both to the patient and to the family members. So to me, that's like the trigger to start to think about treating the hallucinations. And I think, as we were saying, the first step is to see if there's a culprit in the medications that they're already taking that you can do something about before adding something else. Maybe some of the Parkinson's medications can be adjusted. Maybe they're taking an over-the-counter cold medication that can do this.
But we know that dopaminergic medications,
like
L-DOPA and dopamine and dopamine agonists can all induce these kinds of reactions.
So adjustments to that can be the first step to, and that may get rid of the hallucinations or delusions without having to add something else.
I agree. I mean, I think over time, there's lots of things we can discuss here in terms of assessment and management, but since we're on medication adjustment, I think over time, patients just tend to accumulate more medications. Doctors are in the habit of adding things to treat symptoms. It's rarer that the physician will take a look and say, what can I actually take away and still not suffer a major deficit in terms of their Parkinson's symptoms.
Right.
But many times we just can't.
So there's a balance.
There's a balance. We can't reduce medication because that compromises motor function. And when that happens, what do we do?
Well, Rachel mentioned this first step of evaluating, and I think another, a couple of key steps in terms of psychosis is one is to make sure there's not an acute medical condition happening. Right. Does the person have a urinary tract infection that may be causing this hallucination? Usually you're able to distinguish that kind of a syndrome, which we often call delirium, from more pure Parkinson's psychosis. I think education and behavioral strategies are very important in the management of psychosis, letting the patients and the caregivers know why are these symptoms occurring. And there may be some easy, simple behavioral strategies, turning on lights in a room so that it decreases the likelihood of a visual hallucination, removing the person from a room that's bothersome to them in some way. So there are very simple behavioral strategies. But at the end of the day, sometimes we do have to resort to using antipsychotic medications for the treatment of psychosis.
And tell me a little bit about what those medications are.
So there's a range of antipsychotics that have been available for many, many years, going back 50, 60 years in psychiatry now. First, we had what were called the typical antipsychotics, and then more recently the advent of what are called the atypical antipsychotics. In general, Parkinson's physicians have tried to use the atypical antipsychotics, which have less blocking of this dopamine system that we worry about so much in Parkinson's disease, and have more of an impact on what we call the serotonin system. And there's a range of those medications available, and one that's particularly used in Parkinson's. And then finally, we can come back and discuss this more. There's been a newer medication just introduced in the last few years that's specifically approved for Parkinson's psychosis.
And what's that? That's
called pimavanserin,
right.
And that's a medication that affects just the serotonin system. It doesn't impact on dopamine at all.
So in my experience, we used to use a drug called clozapine, which required blood monitoring, and then of course there was Seroquel, right? And none of those were actually indicated for Parkinson's disease, but we used them because they were helpful often. And pimavanserin is the first one that's actually indicated for the treatment of Parkinson's psychosis. Effective?
I think so. I mean, I think that for me, the proof is in the randomized controlled trials that are the most scientifically rigorous studies. And it was on the basis of a one pivotal trial that led for pimavanserin to be approved by the FDA. So to me, that's the demonstration that it's shown to be what we call efficacious. I think, as you noted already, clozapine in some earlier studies was also shown to be efficacious. And I think that's a treatment alternative as well, as although there are limitations.
But it does require regular blood monitoring,
it
so it's a
requires
little bit difficult to prescribe.
And we know that less than 2% of prescriptions for antipsychotics are for clozapine, and I think it's for the very reason you said. Quetiapine, which continues to be the most commonly used medication, is used, I think, on the basis of our familiarity and comfort with using it, but less on any scientific evidence to support it.
The only one I would add, right, is the class of drug, Dan, that you mentioned already for the cognitive parts of Parkinson's disease. And I think these things are correlated, right? So psychosis, it doesn't have to be, sometimes it's just related to medication, but psychosis and cognitive issues can travel together over time in Parkinson's disease. So one of the classes of drugs, the cholinesterase inhibitors that are used for memory or other cognitive issues, they can be helpful for treating the hallucinations that are seen with Parkinson's disease. And I've actually had a lot of luck with those.
Right, I agree, and I think I'm glad you mentioned that. You already mentioned before that one of the risk factors or precipitants sometimes of psychosis can be the use of anticholinergic medications that can cause hallucinations. And what you're positing here is the opposite of that, enhancing cholinergic function may be a treatment for psychosis. And there are studies that are ongoing and planned studies that really want to test formally whether cholinesterase inhibitors are an effective treatment.
I just want to, because you mentioned pimavanserin, and it is the only drug that's actually indicated for the treatment of Parkinson's psychosis, there has been a lot of publicity lately about side effects, particularly early deaths in patients on these medications. I know that's a controversial issue, but is there any reason for us to fear that that's a valid concern?
I think based on the available evidence, and again, the most scientifically rigorous evidence would come from the randomized controlled trials, there really isn't data to suggest that there's clearly an elevated risk of mortality or morbidity, so death or significant medical conditions. The studies did show a slight increase in adverse events or serious adverse events with pimavanserin, but not clearly with deaths. Subsequent to the approval of the compound, there's even been another study in Alzheimer's disease patients with pimavanserin, and that did not show any risk of increased deaths in that study.
And it's a vulnerable population. I mean, these are older, more vulnerable individuals as well. And I think is there any difference between the other antipsychotics and death rates and things like that?
So we had done some previous research with the existing antipsychotics, which was the pre-pimavanserin approved antipsychotics, including quetiapine and other commonly ones used for Parkinson's psychosis, and showed that similar to Alzheimer's disease, there may be an increased risk of mortality associated with other antipsychotic use in Parkinson's. And as you mentioned, patients with Parkinson's disease and psychosis have an elevated risk of mortality just on the basis of that.
Right. So again, I think the summary here is that yes, this is a problem of concern, particularly in patients with advancing disease on higher doses of anti-Parkinson medication, but treatable. And fortunately, in our lifetime, we've seen the evolution of treatments for many of these neuropsychiatric symptoms that have really helped improve the quality of life for patients with Parkinson's. I really just want to have a brief discussion before we wind down of the impulse control issue, because it's another drug-induced problem that can be very disabling. And just for patients to recognize, just tell us a little bit about impulse control disorders. What are they, and which medications can cause them?
So going back about 15 years ago now, with the introduction of the newer dopamine agonists, it's a class of medications, there came to the fore the recognition that some patients can develop what we call compulsive behaviors, just to categorize them that way. And the four primary ones are compulsive gambling, sexual behavior, buying, and eating. And for many, many reasons, they seem to be associated with this class. They don't often appear immediately after introduction of the medication, so you really have to monitor patients long term, and they may be associated with higher dosages of these medications. And when they occur, they can be quite a problem for patients and their families, because they can lead to financial risk, they can affect marriages, they can cause ill health in some ways, and the behaviors are often secretive and shameful. They can be quite a problem.
And the specific behaviors, things like compulsive gambling, hypersexuality, things like that, compulsive buying, compulsive eating.
It really can manifest in any number of ways. Anything where the behavior becomes repetitive and excessive and then harmful in some way.
Mm-hmm.
And again, these symptoms will go away with the removal of the offending agent. So
Right.
you take away the medication and the symptoms will gradually abate.
Right, and I've definitely had some patients who have had some less severe version. You know, like it hasn't necessarily gotten to the point of what Dan's describing and caused major distress, but when taken off the agonist, we'll notice that they're sort of like how obsessed they were with going around trying to find the perfect necklace to wear with the outfit, you know, seemed to have stopped. And they didn't really even notice it until the dopamine agonist was taken off. So now that you know, talking to people in therapy and they share more of these things, I think there's actually like a pretty interesting spectrum.
Right.
You know, of less severe versions
That people live with.
that people live with.
Yeah, you're good at pointing out, I think, because you see a different population maybe in some ways. I see them as severe cases.
Yeah.
But I think just as you said with hallucinations, there are many minor cases that don't need treatment. There's actually people that feel that these medications enhance their
Yes.
creativity and
I
may
have
cause
had
them to
that
become
too.
more artistic or write more. And to
Right.
them, they find it as pleasurable
Right,
and,
or
and
kind
not
of
a
more
problem.
productive in what they're
Right.
doing. I've definitely had some people who feel lost when the meds are
Yeah,
taken off.
that's
So
because of that.
interesting. I want to thank my colleagues and panelists, Dr. Dan Weintraub and Dr. Rachel Gross. On behalf of the Panorama Patient Education Network, I'm Dr. Matt Stern. Thank you.